Welcome to the Radonc Smart Review Head and Neck Cancer Series. This session is really designed to be a comprehensive tutoring resource. We're targeting what I think is the most challenging and, frankly, the most rapidly evolving area in our field right now.
Absolutely. Today, our focus is tackling the management of HPV-positive oropharyngeal cancer. We're going to concentrate on that interplay between transoral robotic surgery, or TORS, and all these treatment de-intensification strategies. This is, a foundational topic for anyone practicing or even just learning radiation oncology today.
I couldn't agree more. This is exactly where clinical practice, enthusiasm, and hard evidence really collide. As residents are preparing for their oral boards, this decision, matrix TORS versus definitive treatment, and then who gets de-escalation, it's guaranteed to be tested rigorously.
And here's the core tension we really have to unpack.
Yeah.
HPV-positive OPC is a highly curable disease. Standard high-dose chemoradiation, it delivers a phenomenal prognosis. We're talking 5-year overall survival consistently exceeding 85%. And this success, paradoxically, is the problem. It fuels this massive enthusiasm to reduce treatment intensity, to preserve function. But enthusiasm is not evidence. We've seen multiple de-escalation strategies just falter when they're subjected to phase 3 rigor.
That's the key.
So our goal in this exploration is to really distinguish the proven board-safe standards from those strategies that, remain purely investigational and just shouldn't be implemented in standard practice yet.
That distinction is absolutely critical. By the time we finish this discussion,
Right.
you will understand the strict criteria for TORS candidacy. You'll be able to navigate the Aaron E3-311 risk stratification, and you'll grasp the profound implications of why NRGHN005 closed its dose-reduced arm.
And have clear, nuanced answers ready.
Exactly. Okay, so let's anchor all this theory in a real patient scenario, because that decision matrix is often the hardest part.
Perfect. Let's introduce a patient who sits right at that clinical crossroads.
All right. Our patient is a 54-year-old male, and importantly, he's a never smoker. He presents with about a 2-month history of a painless mass on the right side of his neck. He has no alarming symptoms, no blood in his saliva, no difficulty swallowing, no unexplained weight loss.
And on physical exam, we find that classic nodal presentation. It's a 2-centimeter firm mobile mass, and it's localized to the right level 2A region. This is textbook. Level 2A is the primary drainage basin for the tonsil.
Exactly. So our flexible laryngoscopy confirms the primary tumor. It's a 1.5-centimeter exophytic mass localized to the right tonsil. And it's well lateralized.
Which is a key detail.
It is. It means it stays nicely contained on one side, doesn't cross the midline, and it doesn't extensively involve the soft palate or the base of the tongue. This just screams good surgical access.
And the imaging findings support this favorable presentation. You've got a 1.8-centimeter primary and that single 2.2-centimeter node in level 2A. And crucially, the radiologist explicitly states there is no evidence of radiographic extranodal extension on the MRI or the CT scan.
A PET CT confirms FDG avidity only at the tonsil and that level 2A node, and thankfully, no distant metastases. The pathology is conclusive.
Yeah.
Squamous cell carcinoma with P16 immunohistochemistry diffusely positive.
Which confirms its favorable HPV-driven biology.
Right.
So, staging this patient according to the American Joint Committee on Cancer, AJCC 8th edition criteria for HPV-positive oropharyngeal cancer, that places him at T2N11M0. And given the favorable biology defined by the 8th edition, this is stage 1.
So the console question we're facing now is the main clinical tension driving this entire field.
Right.
Should this patient undergo TORS with a selective neck dissection, followed by risk-adapted adjuvant therapy? Or should we just proceed immediately with definitive radiation-based treatment?
And if we choose TORS, what are the specific pathologic findings that will trigger full chemoradiation versus, say, de-escalated radiation or even just observation? This patient is perfect for this discussion. Let me deliver the 60-second board script exactly as you would on your exam to frame the optimal response.
Okay, let's hear it.
This is a 54-year-old never-smoking male with P16 positive right tonsillar squamous cell carcinoma, clinical T2N1M0, stage 1 by AJCC 8th edition. The standard workup includes flexible laryngoscopy confirming a lateralized primary, contrast-enhanced CT or MRI, PET CT for staging, dental evaluation, and multidisciplinary tumor board discussion. For lateralized T1 to T2 primary without radiographic extranodal extension, both definitive radiation or TORS with selective neck dissection followed by risk-adapted adjuvant therapy are guideline-consistent options. Definitive IMRT is standard and should include concurrent cisplatin for higher-risk features such as bulky nodal disease, multiple nodes, radiographic extranodal extension, or T3 plain disease. For this favorable stage 1 presentation, radiation alone can be reasonable depending on institutional practice and patient factors. If TORS is performed, adjuvant therapy is determined by pathologic risk stratification. Observation for low-risk disease, radiation alone for intermediate risk, and chemoradiation for high-risk features, including positive margins or significant extranodal extension. Key late effects to counsel include xerostomia and dysphagia with radiation, and potential bleeding risk and swallowing changes with surgery.
That initial consult framing is solid. And I think the critical piece of context you added, that risk of combining surgical morbidity with full-dose radiation, that's really what drives the selection process.
Yeah.
So let's delve into TORS itself. Why did this robotic approach represent such a major paradigm shift in treating the oropharynx?
Well, the shift is entirely functional. Before TORS, if a surgeon wanted to access the tonsil or the base of the tongue to get clear margins, especially for anything beyond a superficial lesion, they were often forced to split the jawbone.
A mandibulotomy.
Exactly, a mandibulotomy. This required extensive reconstruction, often using soft tissue flaps, and this high morbidity surgery, when you combined it with postoperative radiation, led to just devastating long-term side effects. We saw very high rates of osteorating necrosis, chronic pain, and profound debilitating dysphagia.
So TORS changed all that.
TORS, using the Da Vinci robotic platform, gives the surgeon this high-definition three-dimensional vision and articulated instruments that approach the tumor through the natural opening of the mouth. It completely bypasses the need for the mandibulotomy, and that dramatically reduces the initial surgical insult and so potentially reduces the long-term morbidity.
That reduction in initial morbidity is compelling, but HPV-positive disease responds so well to radiation. Why choose surgery first rather than just going straight to definitive treatment?
The rationale is precision staging. We're using surgery to obtain pathologic certainty. Clinical staging is, unfortunately, highly imperfect. For example, a suspicious node on a PET-CT might just be purely reactive hyperplasia.
Right, which would save the patient from a higher radiation dose.
Exactly. Or, conversely, imaging might miss microscopic extranodal extension, or ENE, which pathologically changes the patient from a moderate risk to a high risk requiring chemotherapy. So TORS converts that clinical uncertainty into pathologic certainty. It allows us to then precisely tailor the adjuvant treatment, if any is needed at all, to the actual risk, not the estimated risk.
Okay, and here's where it gets really interesting and where I think we often see confusion in practice. TORS is not a de-escalation strategy in and of itself. It's more of an enabling technology.
Exactly. We have to hammer this home. TORS is merely a platform that allows for risk-adapted management. The de-escalation, it happens solely in the adjuvant setting.
Meaning, reduced dose or just observation.
Right. If the pathology is truly favorable, what we call low risk, we observe. If it's intermediate risk, we might use 50 grays of radiation alone. But, and this is the big but, if the pathology is high risk, like positive margins or significant ENE, the patient receives the full standard of care. High-dose adjuvant chemoradiation, typically 66 gray with concurrent cisplatin.
And the nuance there is that if they end up needing that full 66 gray chemo after TORS, the overall toxicity burden for that patient is arguably higher than if they had just received definitive 70 gray chemo up front.
I think it is.
They've experienced the insult of the major surgery, the selective neck dissection, plus the maximal radiation and chemotherapy toxicity. It's a triple hit.
That's the core risk. We are exposing, based on the order data, 70% of TORS patients to what might be unnecessary surgical morbidity simply to find the 30% who might avoid or reduce their radiation.
So patient selection is everything.
It's paramount. We must select patients who are most likely to have favorable pathology and avoid TORS in those who are highly likely to have high-risk features that are just going to mandate intensive adjuvant treatment anyway.
The entire functional outcome really hinges on that selection process. Let's move on and detail exactly how we scrutinize patients during the workup to determine if they are safe TORS candidates.
Okay, the standard workup needs to be meticulous. And we have to focus specifically on elements that might predict a poor prognosis or limit the surgeon's access.
Let's start with the history. We always ask about smoking, right? Even for HPV-positive patients.
That history is critical because while HPV-driven cancers are favorable, the cofactor of heavy smoking, it really mitigates that benefit. A history greater than 10 pack years is commonly used as a prognostic cutoff.
And why does smoking matter here?
Well, because smoking introduces concurrent field cancerization, DNA damage, and chronic inflammation that can impair the tumor's response to treatment. And it can potentially increase recurrence rates, even if the primary cause is HPV. This less robust prognosis makes us, less confident in the de-escalation data for this subgroup.
And then, of course, the physical exam and the scope.
Flexible nasopharyngeal laryngoscopy is absolutely mandatory to map the primary extent. We need to assess its size, its involvement with the soft palate, the lateral pharyngeal wall, and its relationship to the midline of the tongue base. If that tumor is central, it implies a bilateral spread pattern and a functionally debilitating resection, which really pushes us toward definitive radiation.
On the imaging side, we require a contrast-enhanced CT or MRI of the neck, but I find most surgeons and radiation oncologists really prefer the MRI.
Yeah, MRI is generally preferred for its superior soft tissue resolution. It helps immensely in assessing the true extent of the primary within the base of the tongue musculature and determining subtle signs of perineural invasion. We then rely on the PET-CT for the initial nodal and distant metastasis staging.
And let's not forget the required pre-treatment assessments.
Essential. A dental evaluation is mandatory before any radiation. And a comprehensive speech and swallowing baseline assessment is critical. We often use the MD Anderson Dysphagia Inventory, the MDAD-I score. Establishing this baseline is vital because it's the quality of life metric we're trying to preserve with de-escalation.
Okay, now let's focus tightly on TORS candidacy. What prevents the surgeon from proceeding just based on access?
The robot needs room to work. So if the patient has limited mouth-opening trismus, a narrow mandibular arch, large bony growths called mandibular tori, limited neck extension, or a short distance between the hyoid bone and the chin, access is compromised. Inadequate access means a high risk of positive margins or just an incomplete, unsafe resection.
And if the access is fine, what tumor factors would steer us away from TORS? Our case patient, the lateralized tonsil, was ideal.
We're talking about factors that require large, functionally morbid resections. So anything involving the midline base of tongue, anything requiring an extensive resection of the base of tongue musculature that crosses more than 50% of the tissue, or anything involving the soft palate, these resections just inherently carry high functional morbidity.
Which makes definitive radiation the better choice.
Exactly. It's the preferred outcome preservation choice, knowing the patient is highly likely to need radiation anyway.
And what are the physical limits near the great vessels?
Vascular integrity is non-negotiable. A retropharyngeal carotid artery position, close proximity to the carotid bulb, or clear encasement of the carotid artery on imaging are absolute contraindications. The risk of intraoperative or postoperative hemorrhage is catastrophic. And as we'll discuss later with Order 2, it's a real and lethal risk.
The final nail in the coffin for upfront TORS is seeing high-risk nodal disease preoperatively.
Correct. Radiographic extranodal extension, or ENE, seen on imaging or matted nodes preoperatively. If we see definite radiographic ENE, we know the patient needs concurrent cisplatin and 66 gray of radiation. Performing the TORS first simply adds surgical morbidity unnecessarily. It sets them up for a combined toxicity that is often much worse than definitive chemoradiation.
Let's solidify this into an if-then framework.
Yeah.
I think that's excellent for rapid-fire board review.
Okay.
Start with the ideal surgical candidate, like our case patient.
Okay. If lateralized T1 to T2, good access, no radiographic ENE or matted nodes, and a low smoking history, TORS with selective neck dissection is a reasonable option. We're essentially betting on favorable pathology.
What if the primary looks bad from a functional standpoint?
If you have a central base of tongue tumor, extensive disease, or poor access, definitive chemoradiation is preferred. We're prioritizing functional preservation over that small chance of avoiding radiation.
What about bulky, high-risk nodal disease preoperatively?
If radiographic ENE or matted nodes, definitive chemoradiation is preferred to avoid that severe combined modality toxicity. We also strongly lean toward definitive chemoradiation. If you see 5 or more suspicious nodes on imaging.
Why is that?
Because the E3311 trial showed that 5 or more positive nodes pathologically immediately allocates the patient to the high-risk, full chemoradiation arm anyway, so why do the surgery?
Right. And summarizing the smoking factor again.
If the patient is a heavy smoker, greater than 10 pack years, you have to recognize the diminished benefit of de-escalation. definitive chemoradiation may be the safer oncologic approach, particularly for anything T2 or greater.
Let's quickly cover the surgical and radiation fields correctly. For our right tonsillar primary, what levels must be addressed?
The primary drainage is highly predictable, ipsilateral levels 2, 3, and 4. Level 2A is the most critical first echelon node.
And when do we worry about the retropharyngeal nodes, the ones that require a posterior field adjustment?
Only when the tumor extends posteriorly to involve the soft palate or the posterior pharyngeal wall. For a well-lateralized tonsillar primary, like our case, we typically omit the retropharyngeal nodes.
How does this translate to the selective neck dissection the surgeon performs?
Levels 2 through 4 are the standard selective neck dissection. Level 1B is included only if there's tumor extension anteriorly, say toward the oral cavity or floor of mouth. Level 5 is typically omitted unless there's clear clinical involvement. It's a late echelon node for the tonsil.
Finally, post-TORS, if adjuvant radiation is required, what are the treatment fields?
We have to treat the ipsilateral neck, the levels that were dissected, which are typically levels 2 through 4, and the primary tumor bed. Crucially, the contralateral neck is generally only included if the primary is central, like a large base of tongue tumor, or if we see bilateral nodal involvement preoperatively. For our well-lateralized case patient, we'd likely cover only the ipsilateral neck.
Okay, let's unpack this. Before we get into all the nuances of de-escalation, let's establish the absolute, non-negotiable, proven standards of care for HPV-positive OPC.
Right. For definitive treatment of locally advanced HPV-positive OPC, the proven standard is 70 Gray in 33 to 35 fractions with concurrent high-dose weekly or 3-weekly cisplatin. This is supported by RTOG 1016, which showed just phenomenal outcomes.
We're talking 5-year overall survival consistently above 85%.
And local regional control near 90%. This benchmark is what all de-escalation efforts have to be measured against.
Now, if TORS is performed and high-risk features are found, what's the standard postoperative treatment?
For postoperative high-risk features, which are positive margins or clear extranodal extension, the standard is 60 to 66 Gray with concurrent cisplatin. This practice is validated by the foundational adjuvant trials, RTOG 9501 and EORTC 22931. They establish the benefit of concurrent chemotherapy in the high-risk setting, regardless of HPV status.
Now, for what is promising but still investigational, this all stems from the success of Phase 2 data.
Right. The entire TORS plus risk-adapted adjuvant therapy pathway is, strictly speaking, investigational, because we're still waiting on Phase 3 data. This platform is supported by the Phase 2 E3311 trial.
And specifically within that.
Specifically, the reduced dose postoperative radiation of 50 Gray for intermediate risk patients is an investigational standard. Likewise, observation for the truly low-risk patients T1 to T2, 0 to 1 node, and 0 adverse features is based on Phase 2 data with a very limited sample size. It requires rigorous follow-up.
This is critical board safety information. We absolutely must know what has been proven to be inferior or outright dangerous.
This raises the important question. What should we not do, especially in the definitive setting? First, the systemic therapy choice. Do not substitute cetuximab for cisplatin if the patient is medically fit for cisplatin.
And we have multiple trials showing that.
We do. Trials like RTOG 1016 and DEESCLALATE both demonstrated inferior overall survival for cetuximab compared to cisplatin in HPV-positive disease. Cisplatin remains the systemic agent of choice.
And the second major board trap, which is the definitive dose.
This is non-negotiable. NRGHN005 tested reducing the definitive dose for favorable HPV-positive disease to 60 Gray with cisplatin. That dose-reduced arm closed to accrual on February 3, 2023.
And it closed for a reason.
It failed to meet the non-inferiority boundary. This means 60 Gray with concurrent cisplatin is inferior to 70 Gray in the definitive setting. Therefore, 70 Gray is the only board-safe answer for standard definitive treatment.
Let's quickly review the time benchmarks, because those often appear in written and oral exams.
For definitive radiation, the goal is less than 4 weeks from diagnosis to treatment initiation. Delays beyond this are associated with worse outcomes, though that data is primarily from non-HPV disease.
And for post-TORS adjuvant radiation.
We aim for an interval from surgery to adjuvant radiation of 6 weeks or less. The total package time, from the start of TORS to the completion of adjuvant radiation, should ideally be kept tight, between 11 and 13 weeks. Any delay in initiating adjuvant therapy post-surgery introduces a significant risk of loco-regional recurrence.
We really need to dedicate some significant time to the design and the implications of these key trials. They're not just results, they are the framework for our decision-making.
Absolutely. What's fascinating here is the rigorous design of E3311. It really provided the first systematic, protocolized way to risk stratify patients post-TORS.
So describe the design and the population for us, specifically addressing the staging they used.
Okay, so E3311 was a phase 2 trial. That means it was testing feasibility and safety, not superiority. It exclusively focused on P16 positive OPC patients who presented with clinical T1 to T2 disease, which, in the AJCC 7th edition staging, corresponded to stage 3 to 4A.
And that's a key point. We can't confuse that older staging with the current 8th edition.
Right. All patients were treated with TORS first, followed by a selective neck dissection, and then they were stratified by the final pathology.
Let's detail that LIH risk stratification. This needs to be memorable for everyone listening.
Okay, we use the LIH groups based on pathologic findings. The low-risk group, which was roughly 11% of the cohort, had the most favorable pathology. T1 to T2 primary, 0 to 1 positive nodes, entirely negative margins, and absolutely no adverse features like ENE, PNI, or LVI. Their treatment, observation. They walked away from surgery with no further therapy.
And the intermediate risk group was the majority. What features placed a patient in that group?
They had negative margins, but less favorable nodal or invasive features, so 2 to 4 positive nodes, or PNI or LVI. Or critically, they had microscopic ENE that was below the trial-specific pathologic threshold for high risk. These patients were then randomized to 2 radiation-alone arms, 50 grays and 25 fractions versus 60 gray and 30 fractions. The hypothesis was that RT alone, without chemotherapy, would be enough.
And then the high-risk group, which mandated the traditional intense treatment.
High risk meant adverse pathology that significantly compromises local control. We're talking positive margins, so tumor on insignificant ENE above the trial threshold, or 5 or more positive nodes. These patients were pulled out and received the maximal adjuvant treatment, 66 gray with concurrent cisplatin.
And what did the results teach us?
Well, oncologically, the outcomes were excellent across the board, with overall survival exceeding 90%, which just confirms that the HPV biology is robust. The low-risk observation arm showed good progression-free survival, but, and this is a critical caveat, the few recurrences that did occur in this low-risk group were exclusively in the N1 patients.
Not the N0 patients.
Correct.
Okay.
Which suggests that even N1 disease, despite being low risk by their definition, requires extremely rigorous surveillance if you choose observation. In the intermediate risk arm, the lower dose, 50 gray, was favored for its reduced toxicity compared to the 60 gray arm, and it showed equivalent disease control.
Let's provide the critical appraisal of this phase 2 data. What should we be telling an examiner?
First, it's phase 2. It cannot definitively prove that this pathway is equivalent to or better than the definitive 70 gray standard. Second, the surgical credentialing was rigorous. These were highly experienced centers, meaning generalizability might be an issue. And third, we have to note the AJCC 7th edition staging was used.
And that crucial detail on the ENE threshold. This is where the real nuance lies.
It is. Pathologists often struggle to agree on what constitutes microscopic versus significant, ENE. 3311 used a trial-specific measurement, a threshold to define which ENE put a patient in the intermediate versus the high-risk group. We can't assume that every pathology report outside of this trial is applying that exact, nuanced measurement.
So applying this framework requires really close coordination with your pathologist.
Absolutely. So in conclusion, E3311 provides proof of concept that TORS enables risk-adapted therapy, but that phase 3 confirmation comparing TORS plus de-escalated RT to the definitive standard RT, well, that's still the missing piece of the evidence.
Right. And if we connect this to the bigger picture, HN005 is arguably the most important data point for board safety today because it defines what we cannot do definitively.
That's right.
Describe the trial's hypothesis.
It tested whether we could reduce the definitive radiation dose for favorable HPV-positive disease. They randomized P16 positive, T1 to T3, N1 patients with a low smoking history to either the standard arm, which was 70 gray with cisplatin, or the investigational de-escalated arm of 60 gray with cisplatin.
And the result was a major wake-up call for the community.
It really was. Arm 2, the 60 gray plus cisplatin arm, closed to accrual on February 3rd, 2023. It failed the non-inferiority boundary, meaning the lower dose did not provide equivalent outcomes, and it hit the futility boundary. Survival and locoregional control were simply worse in the 60 gray arm.
So the clear conclusion, which must be repeated for the examiner,
is that 60 gray with concurrent cisplatin should not be offered as a standard definitive dose-reduced option for HPV-positive OPC. 70 gray remains the standard definitive dose. This data confirms that even in this highly favorable biology, there's a real risk of undertreating microscopic disease when you reduce the primary dose.
Now let's talk about ORATOR and ORATOR 2. These trials attempt to answer that core question directly. Does TORS actually offer a functional advantage over definitive radiation?
Yeah, ORATOR, the first one, was a phase 2 trial that compared definitive RT70 gray plus chemo if node positive versus TORS plus risk-adapted adjuvant therapy. The primary focus was function, specifically dysphagia.
And what was the finding on the primary endpoint, the MDADI score?
It was surprising to many. The median one-year MDADI score statistically favored the radiation arm. It was 87 versus 80 for TORS. Now, while a 10-point difference is generally considered clinically meaningful, even the 7-point difference favored the non-surgical approach.
And what was the key clinical reality check that ORATOR provided about the whole TORS pathway?
It confirmed that 70% of the TORS patients required adjuvant radiation and 24% required adjuvant chemoradiation. This data definitively refutes the idea that TORS is a pathway to avoid radiation for most patients.
It's a pathway to risk stratify.
Exactly, a pathway to risk stratify the required intensity of their treatment.
Now, ORATOR 2, which focused on de-escalated RT versus TORS, raised a really serious safety flag.
It did. ORATOR 2 compared de-escalated radiation 60 gray plus chemo versus TORS, and that trial closed prematurely in November 2020 after 2 treatment-related deaths in the surgical arm. Both were due to postoperative hemorrhage.
2 deaths in a small phase 2 trial is an alarmingly high mortality rate for an elective cancer procedure. What does this tell us about the general applicability of TORS?
It raises profound concerns about general surgical safety and protocol adherence outside of highly specialized settings. Specifically, E3-311 had mandated prophylactic external carotid artery ligation for certain higher risk base of tongue resections, a protocol that was not enforced in ORATOR 2. The lesson is that TORS is highly operator-dependent. It requires high-volume expertise and demands standardized, rigorous vessel ligation protocols to mitigate the risk of catastrophic bleeding. The outcomes in ORATOR 2 strongly favored the radiation arm.
We've established that 70% of TORS patients will need radiation. This technical planning is complex because you're treating a shifting postoperative bed and a dissected neck. This section needs some detailed attention.
Absolutely. And accurate planning relies on sophisticated image fusion. The simulation setup is standard supine, thermoplastic mask, arm retractors, but we must fuse the contrast-enhanced CT simulation with the preoperative MRI and PET-CT. The postoperative defect alone is not enough.
So let's discuss the challenging process of target volume delineation. How do we define the primary bed, or the PTV, when the tumor is gone and all the tissues have shifted?
We use the preoperative MRI fusion to define the original gross tumor volume, the GTV, where the primary was located. We then expand this GTV by 5 to 10 millimeters to create the clinical target volume, or CTV, respecting anatomic barriers. Surgical clips, if the surgeon places them, are immensely helpful in mapping the resection margins.
But they can't replace the fusion.
They cannot. A major pitfall is relying solely on the postoperative defect, which often shrinks or shifts away from the original tumor extent.
And defining the neck, PTV.
We treat the dissected levels for our tonsil patient, that's typically ipsilateral levels 2 through 4, and we often include one adjacent level. The PTV has to encompass the entire surgical bed and the lymphatic pathways. We only treat the contralateral neck if the primary crossed the midline, or if there was bilateral nodal involvement preoperatively.
Let's review the dose prescription based on E3311 again, focusing on the intermediate and high-risk differences.
Okay. For intermediate risk, We deliver 50 grays in 25 fractions to the primary tumor bed and the dissected neck. Adjacent subclinical regions, like level 5 or the inferior aspect of level 4, would typically receive 54 gray. And this is RT alone.
And for high risk?
High risk requires maximum intensity. We prescribe 66 gray to the tumor bed and involved nodal regions, always with concurrent cisplatin. Again, subclinical regions receive 54 gray.
The true art here is balancing that dose coverage with organ at risk, or OAR, sparing, especially since these patients already have a surgical insult.
Minimizing late effects is paramount, particularly dysphagia and xerostomia. Our OAR priorities are, first, the parotid glands. We strive for a mean dose of less than 26 grays to at least one gland. Second, the pharyngeal constrictors. The mean dose to the superior and middle constrictors must be rigorously minimized. Damage here directly correlates with late dysphagia. Third, the oral cavity to minimize mucositis. And fourth, the mandible, keeping the max dose below 70 gray to prevent osteoradionecrosis.
And just summarize that key planning pitfall again, the geographic miss.
The primary technical pitfall is failing to fuse preoperative imaging. A surgeon may achieve clear margins, but microscopic disease patterns might extend beyond that postoperative defect. If the radiation oncologist delineates the PTV based only on the shrunken postoperative cavity in the clips, they risk a geographic miss at the original tumor spread. Fusion with the pretreatment MRI is non-negotiable for defining that original GTV.
Let's bring it back to our case. The T2N1M0 stage 1 never smoker. He is the perfect patient for this TORS decision.
He is.
So as the attending, both definitive RT and TORS are clinically sound options. How do we guide this patient to a choice?
Well, TORS is an excellent option if the patient is highly motivated by the potential to avoid or significantly reduce their radiation intensity, and if they understand the risk of a high morbidity combined treatment. We counsel them using that order data. About 70% will require adjuvant RT, and about 25% will require chemo-RT.
And if they choose definitive RT, what are the parameters?
Definitive RT is the standard data-backed approach. It avoids all that surgical uncertainty. Now, for this highly favorable stage 1 presentation, the decision to add chemotherapy is often debated. While N1 disease often pushes centers toward concurrent cisplatin, some might consider radiation alone, targeting 70 gray, based on the extremely favorable prognosis.
Yeah.
However, for a Bohr answer, the safest and most robust option remains 70 gray plus cisplatin for any N1 disease.
So when we're counseling, we have to start positively and then lay out the risks transparently. I always start with the prognosis.
Exactly. I'd say something like, you have an early-stage cancer caused by HPV. The outcomes are exceptionally good, with cure rates well over 90%, so we are primarily debating quality of life and side effects.
And how would you present option 1, the definitive radiation?
Option 1 is 7 weeks of daily radiation treatments, likely combined with chemotherapy. This is our standard approach, backed by decades of proven data showing the highest cure rates. The trade-off is high acute toxicity, a severe sore throat, fatigue, loss of taste, and long-lasting side effects like dry mouth and chronic dysphagia.
And option 2, TORS.
Option 2 is robotic surgery through your mouth, followed by a neck dissection. The goal is to obtain pathology. The advantage is that approximately 30% of patients like you have such favorable findings that they may avoid radiation entirely. The disadvantage is the upfront surgical risk, the uncertainty of treatment duration until the pathology returns, and the fact that if we find high-risk features, the total treatment burden surgery plus full chemo-RT may be harder on you than if we had just done radiation upfront.
So the similarity in overall cure rates means the decision is purely a trade-off between upfront surgical morbidity versus the risk of long-term swallowing issues from radiation.
That's the conversation.
Okay, so toxicity management is critical, especially when comparing these pathways. Acute effects are different. What are the key acute morbidities from TORS?
Acute TORS morbidity includes pain and agenophagia lasting 1 to 2 weeks, often requiring short-term narcotics and feeding tube support. Most importantly, that critical bleeding risk occurs between days 5 and 14 post-surgery when the necrotic eschar separates from the surgical bed. Aspiration risk is also high, particularly after large base of tongue resections.
And adjuvant RT brings the standard array of acute toxicities.
Yes, peak mucositis in Wentz 3 through 5, dermatitis, fatigue, xerostomia. The team has to be proactive with nutritional management, often prophylactic feeding tube placement, to prevent weight loss and dehydration.
Let's focus on the signature late effect. Dysphagia, just what we're trying to mitigate with de-escalation, but it's often exacerbated by combined treatment. What are the specific drivers?
Dysphagia is driven by two mechanisms that are additive when you combine TORS and RT. First, the surgical driver. Resection of the base of tongue musculature directly impairs tongue-base retraction, a crucial movement for propelling food. Second, the radiation driver. Radiation to the pharyngeal constrictors causes progressive fibrosis. This turns the muscular structures into stiff, non-contractile bands.
So you have a mechanically defective tongue base from the surgery.
And a fibrotic, non-contractile pharynx from the radiation, especially chemoradiation. That combination leads to the worst long-term swallowing outcomes. Higher doses per fraction also increase the risk.
And how does this manifest clinically for the patient? And that's not a sudden thing, right?
No, it's rarely a sudden inability to swallow. It's a chronic functional impairment. The patient reports food sticking in their throat, long meal times, sometimes taking 30 to 40 minutes to eat a small meal, the need to wash down every bite with liquid, and ultimately avoidance of dry, challenging textures like steak or bread. And we must be mindful of silent aspiration, which can lead to recurrent pneumonia.
And what's the required surveillance protocol for that?
Ongoing surveillance is mandatory. We use MDA-DI scores at every follow-up visit. If the patient reports symptom or their score declines, we proceed to a modified barium swallow study. We're constantly monitoring nutritional status, weight, and we have to have dedicated involvement from a speech pathologist for swallowing exercises. It's essential.
We've covered the content. Now let's convert it into board-safe language by reviewing the common traps examiners might set.
Okay, trap 1. Offering 60 gray as the standard definitive dose for HPV-positive oropharyngeal cancer.
The examiner asks the dose for locally advanced disease, and you hesitate or mention 60 gray. You fail. NRGHN005 confirmed that 60 gray failed non-inferiority compared to 70 gray. The only correct answer for definitive treatment is 70 gray in 33 to 35 fractions with concurrent cisplatin.
Trap 2. Recommending TORS for a central base of tongue primary or extensive disease requiring a large resection.
Right. If the examiner describes a base of tongue tumor crossing the midline requiring a major functional resection, TORS is generally contraindicated. It's for lateralized resectable primaries. Your answer should favor definitive chemoradiation to preserve function.
Trap 3. Applying E3311 criteria to HPV-negative disease.
This is a subtle one. The examiner presents a 30-pack-year smoker who is P16 negative, and you cite E3311 criteria to recommend observation. Incorrect. E3311 enrolled only P16 positive patients. HPV-negative disease has a fundamentally worse biology and does not qualify for these de-escalation strategies.
Excellent. Now let's summarize the 6 non-negotiable clinical pearls.
Okay, Pearl 1. 70 gray with cisplatin remains standard for definitive treatment of locally advanced HPV-positive oropharyngeal cancer.
NRGHN005 confirmed the failure as 60 gray.
Pearl 2. E3311 is phase 2, not phase 3, and should guide, not dictate, practice.
Confirmatory phase 3 data are still pending, comparing the TORS pathway to the definitive chemoradiation standard.
Pearl 3. TORS is a platform for risk stratification, not inherent de-escalation.
You have to remember that 70% of patients still require adjuvant radiation and 25% require chemoradiation.
Pearl 4. E3311 used a microscopic ENE threshold to separate intermediate from high risk.
This specific definition means close coordination with pathology is necessary to ensure accurate risk grouping.
Pearl 5. Cetuximab is inferior to cisplatin in HPV-positive disease.
RTOG 1016 and DEESCALATE showed worse survival, making cisplatin the preferred systemic agent.
And Pearl 6. Observation after TORS requires truly low-risk pathology and close surveillance, especially for N1 disease.
The recurrence risk is not zero, and the low-risk N1 patients in E3311 were the source of the observed failures.
Let's lock these concepts in with a rapid-fire quiz.
All right, question 1. Low-risk observation. A 52-year-old never-smoking woman has P16 positive tonsil cancer, clinical T2N1M0. She undergoes TORS. Pathology shows negative margins, no ENE, no PNI, no LVI, and a single 1.8 centimeter positive level 2 A node. What is the most appropriate adjuvant therapy? A. Observation. B. RT50 gray. C. RT60 gray. Or D. Chemorati 66 gray.
Best answer is A, observation.
And the detailed clinical reasoning is that the patient meets the E3311 low-risk criteria, a T1 to T2 primary, a single positive node, and no adverse features. This allows for observation with rigorous surveillance.
Question 2, definitive dose. A 60-year-old man with a 10-pack year smoking history has P16 positive base of tongue squamous cell carcinoma, clinical Chi3N2AM0. What's the recommended radiation dose and fractionation? A, 60 gray with cisplatin, B, 60 gray with nivolumab, C, 70 gray and 33-35 fractions with concurrent cisplatin. The best answer is C, 70 gray and 33 to 35 fractions with concurrent cisplatin. And the reasoning here is that this is locally advanced disease, T3N2A, requiring definitive chemoradiation. 70 gray remains the standard dose, as 60 gray failed non-inferiority in NRGHN 005.
Question 3, high-risk ENE. A 48-year-old woman with P16 positive tonsil cancer undergoes TORS. Pathology shows 3 positive lymph nodes with extranodal extension, ENE, and margins clear at 4 millimeters. Per the E3311 framework, what adjuvant therapy is recommended? A, intermediate RT 50 gray, B, intermediate RT 60 gray, C, high-risk chemoradiation to 66 gray with cisplatin,
or D, low-risk observation.
The best answer is C, high-risk chemoradiation to 66 gray with cisplatin.
Exactly. The presence of extranodal extension, even with clear margins, pushes the patient into the high-risk category per E3311, assuming that ENE is above the trial's specific microscopic threshold, and high risk always mandates chemoradiation to 66 gray. One more. Question 4. Choosing TORS candidates. Which of the following patients is the least suitable candidate for upfront TORS with selective neck dissection? A 55-year-old never smoker, lateralized T1 tonsil, N1. B, a 62-year-old light smoker, T2 tonsil, N0. C, a 50-year-old never smoker, T2 base of tongue with central extension crossing the midline, N1. Or D, a 45-year-old never smoker, T2 tonsil, N1.
The least suitable candidate is C, the T2 base of tongue with central extension crossing the midline.
And the reasoning?
That central extension requires a large, functionally morbid resection. It significantly increases the chance of needing bilateral radiation coverage, and it's highly likely to lead to significant dysphagia regardless of adjuvant therapy. This makes definitive chemoradiation the preferred function-preserving route.
So what does this all mean for the future of practice? The field is clearly at an inflection point.
It is. The central controversy remains safety in de-escalation. NRGHN 005 provides a powerful warning that definitive dose reduction is oncologically unsafe. Therefore, the TORS risk-adapted pathway remains the only viable strategy to reduce treatment intensity, but that path is still reliant on Phase 2 data.
And the other major controversy is that surgical safety issue, highlighted by Order 2.
Well,
The fact that the trial had 2 treatment-related deaths underscores that TORS is not a simple low-risk procedure.
no, it demands experienced surgeons operating within highly credentialed centers with rigorous protocols, including prophylactic vessel ligation. This restricts TORS to high-volume institutions, even though the procedure itself is widespread.
So we're essentially waiting for Phase 3 data.
We are. We're waiting for it to confirm if the TORS platform, followed by de-escalated radiation like 50 gray for intermediate risk, genuinely offers a functional or quality-of-life benefit significant enough to justify 2 things. First, the initial surgical morbidity, and second, the potential for slightly inferior oncologic outcomes compared to the bulletproof definitive 70 gray standard. Until that Phase 3 comparison arrives, we are making a best guess on long-term functional trade-offs.
Let's collaboratively recap the essential takeaways from this review session.
First, TORS is a platform for risk stratification. It's used only in well-selected lateralized T1T2 HPV-positive patients without radiographic ENE, and it must be performed at experienced centers.
Second, E3311, a Phase 2 trial, supports the LIH framework. Observation for low risk, RT alone for intermediate risk, favoring 50 gray, and chemord for high-risk patients with positive margins, significant ENE, or 5 or more nodes.
Third, NRGHN 005 demonstrated that 60 gray with cisplatin is inferior to 70 gray. The standard definitive dose remains 70 gray.
Fourth, cetuximab is inferior to cisplatin in this disease setting.
And finally, meticulous image fusion and OAR sparing are critical for post-TORS radiation planning to avoid a geographic miss and mitigate the risk of severe long-term dysphagia.
We've established the standards and the pitfalls in the management of HPV-positive oropharyngeal cancer. It is a field driven by great hope for functional preservation, but it's also guarded by firm evidence on oncologic safety.
Before we close, here is a provocative thought to consider. Given the excellent long-term survival rates and the high rate of patients still needing adjuvant radiation after TORS, should we, as radiation oncologists, be focusing our innovation not on surgery, but on mastering highly conformal definitive techniques?
You mean using proton therapy or advanced IMRT planning?
Exactly. To reduce the 70 gray dose toxicity rather than risking the 60 gray dose failure. The core challenge isn't whether TORS works, but whether the functional gain for the 30% who avoid RT justifies the combined morbidity risk for the 70% who still need full treatment.
That is the ultimate trade-off we face every single day in clinic. Thank you for joining us for this in-depth review.
Complete practice oral boards at radonsmartlearn.com and join us next time. We'll shift gears completely to nasopharyngeal carcinoma, covering EBV-driven biology, unique staging, induction chemotherapy controversies, and the demanding technical aspects of treating this skull-based tumor. Thanks for tuning in.